I'm Daniel Hart. I'm an occupational therapist from the Southern Health and Social Care Trust, and today I'm going to tell the story about how we developed a pre-operative assessment clinic for people awaiting a total hip replacement, and this is carried out in a group format. Our service started in 2008, so we're a relatively young service, and most of the common sort of surgical conditions, surgical procedures carried out on the ward are total hip replacements and total knee replacements. The British Orthopaedic Association recommend that AHPs are involved in pre-operative assessment for total hip replacements, really to start the discharge planning process to help reduce patient anxiety around the pre-operative and post-operative process, and to also educate patients on how to look after their hip replacement as well. So from the start, as a multidisciplinary team, particularly physiotherapists and OTs at the very beginning, we were keen to be involved in a pre-operative assessment. Okay, I can say at the very start we were delivering what the BOA was recommending, but things were a bit messy, okay? And about 2 years ago, what was happening within the acute services was there was a AHP review being undertaken to look at our capacity and demand and trying to weed out any inefficiency in the service. So there were some ideas we had around our pre-operative assessment clinic. First of all, time management was a big issue. In the early days, we very much did one-to-one interviews with the patients. So the physio would have met the patient, had a chat with them, carried out an assessment, then into the OT for an assessment as well. And there was obviously some generic information which was being asked by the physio and being asked by the OT around social circumstances and their functional status and things like that. We were sort of piggybacking on the back of a nurse-led pre-op clinic. So how things were working, we would have been up in the ward and we would have got bleeped by the nurse to come and see a patient. So when you're in the middle of doing something on the ward, it's not the best time to have to go down to your own department. Obviously, that has implications for your own time management, and also the patients may be waiting on you as well. So we decided to go for a group format where we can get all the people in at one time, because a lot of the information, the education component in particular, we were telling the same people on a one-to-one basis. We also had a set time, so that helped us protect our own time, and also meant that the patients knew exactly when they were going to see the OT and the physio. We also devised a questionnaire for the patients to fill in just before they came into the group, which was to capture that generic information both ourselves and the physiotherapists were asking. We also, in the old days, we were very much verbally giving patients information on a booklet and sending them home. And we wanted to explore more different learning aids, so using multimedia. So at the time there was a trust fund called Dare to Do Different, and we applied to get a projector to get PowerPoint. Like, PowerPoint doesn't sound exciting straight away, but it allowed us to, besides putting the text up on the screen, use pictures and videos to show patients different elements of their cure, which we were going to address. The group setting was interesting as well because patients learn from each other. We do keep patients who are maybe coming in for their second operation, so they have a story to tell. And in some of the groups, some of the patients are very keen to sort of share their sort of strategies of how they managed after the operation, and also sometimes can sort of be a positive reinforcements about the benefits of the operation as well. We also arranged with the admin team in outpatients to include a letter along with the nurse for the nurse-led clinic to advise the patients strongly to come to the group, and also encouraging care or family members to attend as well. And the reason around this was, as I think Paul had mentioned in his presentation, was to get clear expectations, not just to the patient but the family, what to expect, and also as a very much a positive reinforcement. So what do we do in the group? I'm just going to run through. First of all, the group really starts to talk about what is a total hip replacement, and briefly describes the sort of surgical procedure as well. And we have a skeleton in the department we use to sort of demonstrate those as well. We also talk about the patient journey, and again, giving the general picture about when you will come into hospital, when you will go home, and telling people that really they more than likely will come on the day after their operation, and they will be up mobilised by the physio a few hours after they return from the theatre. And they're likely to go home on the second or third day as well. And the rehab will continue while they're on the ward. Okay, the surgeons in our hospital recommend 6 weeks as the period for hip precautions to be adhered to. And that really involves avoiding extreme hip flexion, internal rotation of the hip, and crossing the legs or adduction of the hips. And these are again demonstrated with a skeleton and some pictures. Physiotherapist then will go on to talk about her role in terms of mobility, first of all, demonstrating how to use crutches, describing how they will get down to bed the first time after the operation, and how they will practice, maybe initially with a frame, moving on to crutches shortly after. The patients are also free to take the crutches there and then from the clinic, so they can practice them at home as well. Stairs is also, patients are reassured that this is normally not a big issue in terms of after this operation. So, and they will have the opportunity to try going up and down a flight of stairs when they are in the hospital, when they're ready. Physiotherapists then will demonstrate the exercises they need to do to in standing and in supine on a plinth, and that's demonstrated at the group. Occupational therapists then will discuss the solutions to everyday tasks that can restrict hip precautions in those 6 weeks. Okay. We also advise them on individually what the best height of chair and bed they will need, how to get on and off a chair, how to get in and out of bed, and most importantly, there is some restraints in some of the equipment which can be provided realistically from community services. So, for example, we're saying to people, you may have to organise your own chair after the operation, giving them the right height of chair. So, anecdotally, occasionally you get a person who maybe hasn't attended the pre-op clinic and comes on the board with a shopping list of equipment and maybe a shopping list of what care, social services input they want, which may be really unrealistic. So we're really nipping it in the bud, maybe those 6 weeks, 3 months pre-admission, to give the patient a realistic expectation about what is available in the community. Okay. We also show videos about how to get in and out of a car. So again, people are positively being reinforced that they should be able to do this, all being well, after the operation. And again, this takes some of the demand of ambulance services at discharge. Okay, there's a great actor on this video here. It's amazing what you can do with a mobile phone these days. So that's the type of thing we would do at the group. Talk about getting dressed and advising people not to use the bath for 6 weeks. Here's me again. Okay, and some of the small aids which can be used again to give independence for those 6 weeks. Aids which are really there to prevent the hip movements we want to avoid. There is a mistake in this video which I always ask the patients at this stage to try and point out in terms of so anybody feels free to point it out if you remember what not to do. We always decide to show getting dressed first rather than getting undressed first, because there's a bit of a shock value if we do that first. What's going on? Anybody see it? Yeah. Okay, so we're talking about loose clothing, the likes of the long-handled shoehorn, the sock aid, the helping hand. Those three pieces of equipment should allow people to get themselves dressed. Okay, but again, this is very individual. Not everybody's going to fit this picture, but most people should do, and that's a good advice. And this is very a personal preference. Some people are happy for their spouse to help them do these things, or they may be more keen to try the pieces of equipment. In terms of the domestic tasks, there's a lot of, particularly if the person lives alone or has limited support, it's about forward planning, maybe stocking up on ready meals or freezing dinners, kitchen trolleys to transport items around the kitchen, or a stool to sit at. But we do recommend in those early weeks, particularly for heavier tasks like laundry and shopping, they will require support. What else do we talk about? Our patients tend to be quite a broad age range. We get some young people who may be working, so we're talking about getting back to work. When you can get back to work, this guy here needs to get back, and that's very much personal to the job. Obviously, people who have a very manual job may be saying at least 6 weeks, but if you maybe a job which is in an office and you can avoid those movements, you may get back sooner. And the same for hobbies and leisure pursuits as well. Driving is normally at least 6 weeks. And sexual activity, we speak to patients individually about that if they wish. Over the last 6 months, the social worker has become more involved with the pre-op group, which has been really good because, like ourselves at the physio and OT, it's good for the patient to see the people who are also going to be involved in their aftercare, and as well for the social worker. That's a point of contact. Advising people on services or financial issues as well. And also, some people do come to the clinic who are maybe struggling at home, and it's perfect for the social worker to be there and the other two disciplines, because it means we can maybe do something quicker rather than that person struggling until they come into hospital if they need help sooner. Shortly after the group, we do meet on a one-to-one basis, and we have the generic information the patient has provided just at the start of the group. For the physio, that gives them an opportunity to assess the patient, let the patient practice using the crutches. It allows ourselves to identify any potential care needs or which may need to be looked at, or identify any equipment needs as well. I should say first of all that through the Patient Public Involvement Committee, we have recently put together a questionnaire. Over the last year we've been tweaking things, we've been trying to make things a bit more streamlined, better. But it's now time to get the patients the feedback to us. Now, we're in the process of collecting those questionnaires. Out of quick glance, took some in the box just to have a look. And some people just tick boxes, which were all saying positive things. Some people did take the time to write down some nice things, which were all very positive at this stage. But time will tell, and we will evaluate that information in the next few months. We also received a donation from one of the patients who went through the process, and we hope to use that money maybe to help us design a more professional booklet, like a multidisciplinary team booklet to provide to patients. And I think the different mediums, so besides the verbal and the visual, all those things all complement each other. For example, we had a patient with a hearing impairment who attended one of the sessions with a signer accompanied him. So really the visual information complemented that end of things as well. I should also say transferability. At the minute, we are the only hospital in Northern Ireland which is using the group format with the wider MDT involved. So there's some transferability there as well across hospitals. In terms of clinical conditions, there's some transferability there as well. Thinking, for example, people who are maybe coming in for elective amputation, that's quite a life-changing, very much a life-changing operation for anybody to go through. And for AHPs to be involved at that stage to address things like mobility, environmental issues, social issues, could be another way forward. Maybe not so much in a group context with that client group, but also definitely as one-to-one. So that's basically me. Thank you. Anybody got any questions?
What would say have been your biggest impact from your perspective, you know, from the patient's perspective?
From the patient's perspective, definitely the feedback is very positive. Post-op, when we go back to see the people, and they nearly know our names, you know, when we come back and see them, they recognise us at least. And the very rarely is issues. We tend to only have issues with people who aren't pre-op assessed, because those people are sometimes shocked. They're told things which they didn't realise they couldn't do for that short period after operation. So definitely, I suppose the patient's being well informed is really the key thing. And I think some people come to the group maybe not really sure it's really relevant, you know, but when they come and they realise what the homework they have to do, and that without sort of being negative, it's all about positive reinforcement, but at the same time they give them a better idea of what the journey entails, which I think the same issue was brought up in the previous talk as well.
Same themes, managing expectations is a very key element, isn't it? So, excellent.